Good evening to everyone present here with us today. This is Shreyan from IGCP, today's moderator. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Dr. T.N. Ravishankar. Sir is MBBS, DFN Colombo, FCGP, PGDMLE, MBA Family Physician at Sundar Hospital, Chennai. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is metabolic tsunami, tracking obesity, diabetes, and hypertension in primary care. Now, without any further delay, I would like to welcome Sir again at our forum and would like to hand over the session to him. Over to you, sir.
Thank you, IJCP, for giving me an opportunity again to be on this platform to have an insight of the management of the triage of obesity, hypertension, and diabetes, which is the non-communicable disease that creates so much of havoc in the society. And as we, as primary care physicians, we are the people who see these patients at the first instant, and how we go about it, how we detect in the family practice is what's the aim of today's talk is. It's considered the fifth most common cause of death, obesity. Probably this was not a topic 2 decades ago or 3 decades ago, when people had been so much not conscious about their health and obesity, but then they had a lifestyle that was so different that obesity had never been a problem. Today, overweight and obesity are the main lifestyle illness that leads to further health concerns and contributes to numerous chronic diseases, including cancers, diabetes, metabolic syndrome, cardiovascular disease. Once you get your diabetes or hypertension, I think your cardiovascular, renal, nervous system all goes into problem. And analysis from the National Family Health Survey shows that 1.6% of people up to 4.8% are overweight, and then 24% of the women and 23% of the men are overweight or obese in the society. And this is the reason why we are now going to have a talk on this. And this is a common scenario we see. I'll come back again to the slide again at the end of the talk. The first group of people are so happy, but still, I will only say that they could not spend the time sitting easily like the other group who are quite fit and trim. This is where the big difference that has happened in the society. I think everyone is aware. Even children under the age of 5 years do have obesity in them. The adolescent obesity has raised by more than 125% for the girls and 288% for the boys between two of the national surveys that had happened in the last 10 years. ICMR has done a documentation that an alarming 254 million and 351 million adults are either going to be obese, respectively, in India. We do have a day, March 4th, as an World Obesity Day. This is only to bring an awareness in the society that obesity is such a problematic ailment prior to the non-communicable disease getting established in an individual, either diabetes or hypertension or the metabolic syndrome. And so that is why this alarming statistics becomes very, very significant in a family practice. The classification, I think, BMI is the one which is often used with the height and weight ratio that is being measured. And there are situations where a BMI coming within the 25 range are now being overshot, and we call them overweight when the BMI is above 25 and within 29.9 we say mildly increased, but then obese comes above 30, and there are moderate, severe, and very severe depending on the range of 30 to 35, 35 to 40, and above 40, very severe obese individuals. These were not a picture in our country 2 decades ago. And now the cause has already been known to every one of us in our practice. Overeating, old age becomes a sedentary life. Today we have a sophisticated food, at times medications for certain ailments. Stress and poor sleep has been one of the commonest cause of people suffering in the society because of the stress of survival and the stress of coping up with the needs in the society. There are a lot of misinformation in the society with the social media giving lots of hopes and lots of information which are not authenticated. Sometimes people have a family history of being obese, like what we saw in the slide in the photographs. And then sedentary lifestyle is the biggest common cause of obesity. Today, when you have a big waist, it's not possible to classify a person properly, and that is why another new formula has come: waist to height ratio. From the waist above, if your height is half of what your total height is, where is very important to know that the waist height ratio is now the another index by which you can determine whether a person is obese or not obese. And you measure from the hip to the height head, and then the waist circumference divided by the height. If it is 30 divided by 70, 0.4, and if it is less than 7, like we'll see in the next slide, that the obesity is being classified. Somebody with a male 0.63 and for a female 0.58 is highly obese. And we do have the two formulas, and today in why we are now talking about the primary care is all these things were once upon done, measured, weighted, and then we calculated either using your knowledge or using your calculators. But today there are gadgets which directly give you all this information. And what is the use of these gadgets? Again, we'll see at the end of the talk. And there is one great gadget that measures your height, weight, gives the fat measure, give the BMI, fats in the content in the body, and all these things are very, very useful today. This is what we call a digital technology. And there are great pillars to mitigate obesity: setting a goal on your nutrition, setting a goal on your physical activity. There is a behavior of your relationship with food plays a big role in weight management today. Sitting idle long hours in front of the screen trying to work or see or entertain always gives you the pleasure of having a food along with you. Either it is your grumbling foods or a great foodstuffs, and that is the reason for your pushing yourself towards obesity. And most of the time, when you are working, you work overnight without a proper sleep, which also contributes. In spite of medications, there are times when you have to switch over to the bariatric surgery to cope up with the obesity. Now, the next most common cause in the country, the diabetes. I think India is called the capital of diabetes in the world, and there is a big economic growth in the pharmaceutical market because of diabetes in the country. But at the same time, the economics of the Indian population, the country also gets dipped because of this non-communicable disease. Prevalence of diabetes among adults in India is estimated to be 6.5. That doesn't include another 10% who are undiagnosed cases. It is almost 16.1%, where only 6.55% are known to be diabetic and receiving appropriate treatment. There has been a terrible increase since 1990 by more than 140% because of the dietary risk, sedentary lifestyle, and urbanization. More than 50% of the people are unaware of the diabetic status, which leads to health complication if not detected and treated early. And that is where the role of the primary care physicians come into play in a very, very big role and a responsible role by the family physicians in this country. That's a racing graph of the incidence, prevalence, mortality, and disability adjusted life years for diabetic patients in the country over the years. We see this graph going up in the last 20 years, and we have what effort we have taken to reduce the line is still not been productive for us. Government has come itself in a food culture. Government has a policy on food culture to prevent the diabetes becoming a global concern for the Indian population. Next is hypertension, which is also on the rising tide, with 24% having a higher prevalence and women another 21% who fall in the category of hypertensive in the country. And if their increasing age is another contributing factor for a person to be an hypertensive. Older the person, the more you are, the urban you are likely to get more. The urban men have more chances of getting an hypertension than a rural man. The same way for an urban woman getting more hypertension than a rural woman. And statistics by the national survey has given all these indications over the years, and it is also again on the increase. And let's see that one blue graph in the chart where these are the people who need to be identified in the family practice to be taken care and given the appropriate treatment or detected earlier to combat the triage of obesity, diabetes, and hypertension. An early detection is a target in the primary care. It is either a targeted screening or an opportunistic screening. I think every family physician should do have their staff nurses who are there in the reception to take a BP and a weight of all the patients who reach them. Whether he is a patient or an attender coming along, whether he is an adult, a geriatric, or a pediatric. I think this is a simple tool that we can use in our practice, trying to detect either they are obese, hypertension, or a diabetes, or occasionally trying to do a blood test for them in the clinic. When you are trying to find somebody who's a smoker and alcoholic, then you need to be doubly careful and take effort to screen them either with a targeted or an opportunistic. All these things are done primarily to prevent the macro and microvascular complications that can set in a course of time. I do always say to my patients, diabetes or hypertension may not cause a problem immediately like fever, putting you incapacitated, but once they become a complication in your system, then it is very difficult to get it revert back. You have a fever or the viral fever of the season, that influenza or a respiratory tract, then you take care of it immediately because you are incapacitated on the same day. But then this diabetes and hypertension allow you to function your work normally or with a compromise. And so these people don't give much importance to it, resulting in a poor quality of life, and the value of the years that you live are not going to be of your use. And then these are the photographs which I have like everyone to see it out, because the reading of the hypertension, the pre-hypertension, hypertensive, and a resistant hypertension, all these things are there labeled down. 120/80 is a target that we have to keep putting it, even when they are 120 to 139 and 80 to 90 of diastole. That's the place where we have to concentrate, try to give the lifestyle changes that we will see later, so that they don't get pushed out on the right side rather than get pushed out on the left side or trying to be 120/80. And there is always a way how you need to take a BP when the patient walks into your clinic. Allow them to sit, relax for some time. Don't allow them to talk when you are taking the reading, and all that more. The appropriate cuff, relaxed sitting position, and that is how you need to take it, because the BP do change. Even when you tell the patients that I took the BP there somewhere, there are so many restaurants who are now come forward to have a BP, automated BP cuff BP available in their place, allowing them to see the BP. But then you as a professional will need to do it so perfectly, and that is why taking a BP is more important, and more important and much more important is validating your either your automated or your manual BP apparatus. You might have bought an apparatus 2 3 years ago, or there are people who have used it for 10 years. There were times when you used a mercury BP apparatus which had a lifespan of exceeding even the physician or the family physician who is using it. But today the mercury apparatus as it's not in use. We have the digital apparatus or an automated machine or another type of manual machine, and all these machines will need to be validated at least twice in a year or thrice a year, depending on the number of users. And when the BP reading is more than five of difference, try to take 2 3 readings and then take an average of it. And don't try to fix your mind that the patient is either normotensive or a hypertensive on just the first visit alone. Just ask them to come back again after a day or two, then do the reading again, and that will be more useful to label them either a normotensive or a hypertensive. And more important, and today, home blood pressure monitoring has become the norms of the day, that we need to allow the patient to buy a digital apparatus and allow them to teach them to take the BP at home. Whenever they take it, you tell them how to sit and do, and ask them to take the reading at what time of the day and what after work they do the reading, so that the next time when they come to you, you can do a good analysis. Otherwise, you need to have a ambulatory BP monitoring, which is a costly process now. It may cost up to 3 to 5,000, and it will be a difficult one that doesn't allow you to have a good sleep in the night, the cuff getting inflated quite often. To avoid that, I think a home blood pressure monitoring will be useful, but continuous ambulatory BP monitoring will be useful for certain type of patients. And then this is the criteria that we have to do it. And in the ambulatory, there is a range that is being given there, daytime, nighttime, and the 24 hours average is also given. This has to be taken note of when you are trying to put the patients on an ambulatory monitoring BT. Why are we doing all these things? To prevent a secondary complication that can happen to any patients. And then the most important aspect on the obesity side, that when you need to treat it, is to prevent them from taking the top three: the red meat, the processed meat, and the redefined sugars. And you can take a moderate level of low fat dietary products. Poultry, fish, and red wine is allowed to some extent, but all moderate. Moderate means either once in a week or once in a fortnight is allowed. There are monounsaturated fats, example, extra vinegar, olive oil, nuts, fruits, vegetables, legumes, and unrefined whole grain cereals. Whatever that is available in natural is always good for the health. But whatever you are trying to redefine or change it in a present day of scientific growth, I think all results in a problem. And that is why all these things are needed to be changed. In a glycemic target, typically assessed with the HbA1c, are individualized based on factors: life, age, life expectancy, comorbid risk of hypoglycemia, the type of work the individual does it. All these things have to be taken into target when you are trying to treat a diabetic patients, to bring them under a normal status or trying to maintain the status. The level of blood sugar and the level of BP is there given in the chart: a pre-diabetes, normal diabetes, and then the HbA1c trying to be maintained around 7, which will be the best of thing to do it. Anything below 7 will have to be, but you need always to see the laboratory values and under which score they are doing it, and try to find out their normal values and trying to implement on your patients. The Indian specific diet modification are crucial for managing these conditions effectively. Pharmacological, every one of you will be aware, but there are certain things which we need to stress upon as a family physician with the patients. Of course, the diabetologist or a physician or a cardiologist will be doing it, but these patients will visit them once or twice a year, and we are the people who are close with them and trying to do all those things that is being given there. Reduce the refined carbohydrate, which we always see. The Indian diet is often high in refined carbohydrate like white rice and maida. These should be replaced with whole grains such as wheat, jowar, bajra, and millets, which have a lower glycemic index and provide more fiber, which is very, very important to keep them under a normal gastrointestinal motility. Millets are now being recognized and being propagated by the country, by the government of India, mainly for the non-communicable disease management. Decrease oil and salt intake. The oil, which gives a lot of flavor to the food, does not suit your arterial system, and the salt, which gives a nice taste at the end of the food, is not going to be friendly for your system. I think you need to decrease your oil and salt intake. If you do that, if your patient does it on one day when they go out for an outing or a festival or a marriage, I think they need to compensate for the next 1 week, reducing them to a greater extent so that it doesn't get accumulated in the system. But then avoiding it on all those days will be ideal, but it will be impossible at times. Limited processed and fast food. Today, somebody goes for a hard work, fast work, doesn't have time to sit and chew his food and eat. And that is why they take these burgers, pizzas, and samosas, resulting in problem to us. Dietary approach to stop hypertension. That's where your fruits, vegetables, whole grains, and lean proteins. Increase fiber intake with the vegetables, with the raw vegetables and fresh vegetables, so that your bowel is fine and blue. Reduce sugary drinks, that is there, which we stresses for everybody. Now we have the physical activity. A sedentary lifestyle is the one which has contributed large to the NCDs, and that is because of the work pressure for everyone sitting in front of the computers and trying to earn their life, but at the same time killing their life from behind with no aerobic exercise. Aim for at least 150 to 300 minutes of moderate intense aerobic exercise per week. Example, walking, jogging, cycling, and swimming. There are your patients will have certain inclination to do it. Find it out and tell them what they do. Don't keep talking about the walking alone. Somebody who has a flavor for cycling, jogging, or swimming, encourage them to do the same. Indian specific activities. Quite often today, we have the staircases. Let them use the staircases rather than the lift or a traditional physical labor like you have your garden at home. You spend time in your garden. I think that is a very good, entertaining, and encouraging physical activity. Exercise at least 5 days in a week. That's an important one. Reduce screen time in sitting in front of your TV. And there are apps now on your mobile which can always measure your walking steps every day. And 8,000 to 10,000 steps is an effective way to stay active. Weight management, I think we already saw it. Keep seeing your BMI, waist circumference. Try to do what the previous two slides have shown on exercise and diet management. There are times when you have the adolescent, the PCODs, or sometimes you have the issue of insulin resistance or a thyroid disturbance, which can always contribute to the weight management, which need to be identified, and the patient should be asked to evaluate on the same also. Stress management can increase your cortisol level, and if the stress has to be reduced. You need to have a good quality sleep of 7 to 9 hours, and if you are unable to sleep, try to exercise well with yoga and meditation, and breathing exercise can always mitigate your stress and allow you to have a good sleep in the night, which is very, very important. Somebody who's having a night duty or on regular night duties for months and years together do spend that day most of the time having a small nap, trying to do their household work or trying to see their friends and spend that time there. And by that spending that time, it's a temporary entertainment with their friends, but then your system gets degenerated, resulting in all the complications that can happen. Quit smoking, limit your alcohol, avoid negative coping mechanisms. And all these things will be very, very helpful in managing your lifestyle changes. Some of the slides earlier, which I have seen, was not my knowledge. It was the AI generated. which gave us the information, which gives us the information on what you need to do when you have these NCDs. AIs are now cope up well with managing obesity, hypertension, and diabetes. But then the slides hereafter are going to be the one that we are commonly use it in our day-to-day practice. Choosing a right antihypertensive for the patients who have the renal problem or a coronary artery disease, peripheral vascular disease, asthmatics or COPD is all very, very important in our practice. The first line of drug is always your diuretics, thiazides, which now come either in a combination or as a single drug, pharmacological drugs, which has been in presence for years together. There had been certain drugs which have already gone out of the market. Today, we depend most of the time the three major drugs, the AC inhibitors, ARPs, and calcium channel blockers. And there are lots and lots of options in all the three variety of drugs. And even if you go to the beta blockers, you have umpteen number of drugs which are specific for certain situations. Like when you try to treat an asthmatic or a COPD, better avoid a beta blocker. And where there is a very resistant hypertension, you try to assess that more appropriately, and at the same time try to do a combination of drugs to manage the or tachycardia that the person will have. And also if they have certain patients will have a different kind of reaction to certain drugs, which every one of us know. Your calcium channel blockers can cause a pedal edema. Your beta blockers can cause bradycardia, resulting in giddiness or a vertigo, and all these things will have to be reassessed every now and then. And when you are a diabetic patient, we always prefer an ACE and ARBS. And in an anxiety disorder, I think a beta blocker will be more useful. And which of the beta blockers, I think quite a long years have been the atenolol, and today you have the bisoprolol and things coming after that also. And the most important thing that there has to be seen also, beta blockers in somebody who's above 65, 70 years of age, better try to avoid. There are times they would have been taking these drugs for years together comfortably, not analyzing, but there will be one point of time these old age persons will already have a compromised carotid circulation, may have a vertigo, resulting in a giddiness, a fall, and a fracture, which will be detected later, but then the morbidity would already happen with the fracture of the hip. Most often, on a beta blocker, patients need to be assessed regularly, and if they do come to your family practice, I think it is better you firmly tell them to move away from the beta blockers and change them to a better drug which will be more accommodating to them, either as an AC, ARBS, or a calcium channel blockers. Alpha blockers is quite often used for the men who have a prostate enlargement, can be used on both the ways, trying to control the BP and also to manage the frequent urination that can happen. Beta blockers is most ideal in an anxiety disorder. Treating pregnancy and hypertension is something unique, and we have the labetalol today, which is quite often used rather than the alpha dopa, which has been in my days. That was the only drug that was being used in pregnancy. And in peripheral vascular disease, be careful trying to, when you are using a beta blocker, better avoid them the same. And in renal problem, when you are trying to use the AC and ARBS, keep monitoring the creatinine level so that they don't get into a acute and chronic disorder. Now we go on to the diabetic. Diabetics regime is individualized based whether the patient has got a hypertension, a renal compromise, coronary artery disease, a liver pathology where we need to be careful on certain drugs. When there is gastric pathology, most often the gastroparesis is one, and before prescribing, better to analyze the economics of the person and the occupation of the person so that the prescription that you give them is being used regularly or honored so that to keep the diabetes under control. When we have your metformins, the most common drugs which is being given as a first line of drug, and that too in NCDs which have obesity, the most common drug. And the present day, the GI disturbance can always be countered by imiglamin that has been come into vogue. The sulfonylureas, the very strong oral hypoglycemic agents which have been in the past 3 decades are slowly giving way for the DP4 inhibitors and SGLT2 inhibitors, where SGLT2 inhibitors have a very good cardio-renal protective, and the same way for the DPP4 inhibitors have a good usage by the patient rather than the sulfonylureas and metformin combination, for it is much better friendly to the gastrointestinal tract. And if you have an obese person, try to use a GPL1 receptor agonist, though costly, do have a good effect on the obesity. And today the people are started trying to use it for treating obesity alone. But the mainstay on treating a diabetic patient is always the insulin, which is slowly coming in a larger way with the availability of the basal rapid and mid starts. Basal at one time a day in the evening from your guardian and everything, and using an oral hypoglycemic in the morning and afternoon, giving all the benefits of both the insulin and the oral hypoglycemic agents to the patients are useful. In spite of all the prescriptions that you give for a diabetes and hypertension, the most important thing is to monitor the patients whether they are taking it. And for monitoring, the most important thing to prevent the complication is the large set of investigations that need to be given. Certain investigations can be done once in a year, like the echo and ECG, or an urea and creatinine at least once in a 6 month, or microalbumin, HbA1c at least twice a year or thrice a year. Take care of the abdomen, doing an ultrasound to see the kidney size, biotesmetry for the foot care, the carotids and peripheral Doppler to see that there is no vascular problem, retinal examination for the eye, which is the most important. Lipids are the most important thing that need to be seen to prevent any coronary event that can be a complication for them. And today, AI is one other thing that can be very, very useful. The monitoring tool, machine learning approach is a promising solution to early prediction of obesity and the risk of overweight, because it can offer quick, immediate, and accurate identification of risk factors and conditions likelihood. The machine that I showed you when I was trying to talk about the waist hip ratio is a machine that can be used by every family physician, which costs at least nominally, but then it will help you to detect your patients who are prone to be there to become obese or to go in for complications. The same way today, there are watches which detect the sugar level, non-invasive level, and there are BP apparatus in the watch also that can detect and can always use a Bluetooth method for it to reach to you. And this is the way today a family physician shall need to monitor the patient to prevent the macro and the microvascular complications that can set in. Because as a human being, everybody wants to save money for anything else, but not for their medical management. Spending money for the medical management, evaluating their individual is not the priority of most of them. And today, though insurance has penetrated up to 18-20%, it is mainly on the inpatient management. But then AI, as a family physician, suspecting a patient who can go in for all the problem, if you keep doing that, I think that will be a service not only to the patient but also to the nation. That is the goal that need to be done to manage the triage of obesity, diabetes, and hypertension in our practice. Thank you for the wonderful opportunity given by IJCP to talk a bit about the social value and a specific management of the triage of obesity, diabetes, and hypertension. These are the few references that I have taken and utilized. Thank you, one and all, for listening patiently to this talk.
Thank you so much, sir, for this wonderful presentation. We do have some questions if you like to take that up.
Yes, please. Yes, please.
So, sir, the first question is, what are the biggest challenges of primary care physician face in managing metabolic syndrome?
See, first is identification. I think you need to suspect. You need to be aware of what are the components of the metabolic syndrome and what is it which patients present. We always think that there is only an obese person. I think that is where the AA is more useful. You have the ready-made machines that to measure height and weight, and then your diabetes and hypertension need to be assessed everywhere. And forcing the patient or requesting the patient to do this evaluation is very, very important. We are the first point of reach for anybody for management. And if we give them an appropriate advice and give them how to proceed, I think that will be very, very valuable in your primary care. It's difficult to convince the patient, but then your trust with them and trying to predict what can happen, not in a threatening way, but in a nice way to tell them to do the
So
evaluation.
next up we have, how should doctors navigate the growing role of newer agent, example GLP-1 RAs, SGLT2 inhibitors in primary care?
Your line got interrupted. Come again,
Sure,
please.
sure. So the question was, how should doctors navigate the growing role of newer agents, example GLP-1 RAs, SGLT2 inhibitors in primary care?
To find drugs, I think they need to be very careful in utilizing it. GLP-1 is mainly used when you have an obesity person. Google them, get the information, come and ask you whether they can take a GLP-1 to reduce their weight, obesity. But then you weigh the pros and cons between the complications that can happen with GLP-1, and the SGLT2 is one which is very, very commonly used not only by diabetics, more by the cardiologists. Primarily, the drug is now being used not more as a diabetic drug, more as a drug to preserve the hypertension or the patients with a coronary artery disease from progressing in for a cardiac failure or not. I think the only problem with the DPP-4 inhibitors is the urinary tract infection that can happen, candidiasis. Keep monitoring the patients, and then if the patient has got once or twice the urinary tract infection or a candidiasis, I think better avoid the drug. The benefit of the drug is gone when they get the complications of that nature. And a repeated urinary tract infection in a diabetic patient is likely to result in a pyelonephritis or problems to be permanent, and more so in a woman. I think better careful at that point of time. You can avoid taking the SGLT2 inhibitors at that point of time. GLP-1 specifically, I think economics also plays a play in GLP-1 antagonist drugs, and obesity and GLP-1 alone has to be utilized.
So there's one last question. How can we effectively integrate routine screening for obesity, diabetes, and hypertension in busy OPD settings?
I think I told you earlier. I think we have a number of days that have been health days in the country. Every family physician should have their patient's BP checked up in the reception itself with your digital BP apparatus, with your staff nurses, and everybody being taken the BP. I think there will be one point of time you'll be able to pick up the hypertension. The diabetes, it's going to cost you hardly 14 rupees for your strips. It is screening a patient with using your glucometer is one advisable. And I think there are a number of days that are coming. Your diabetes day, World Diabetes Day comes on November 14th. You have your we have our hypertension day, cardiac day is coming. I think these are the days I think that the pharmaceutical companies also come forward to screen a patient, but try to utilize the screening of the patients, try to propagate that the screening has to be done. And if they do have an abnormal reading, then you need to evaluate them appropriately. Screening your patients in a family practice can happen on the specific days that come all through the year. I think that's the way you can pick up, screen, pick up, and then evaluate, then give them an appropriate follow-up so that you don't have a macro and microvascular burden in the society and an economic deformity because of these individuals.
Thank you so much, sir, for answering all our questions. That's all from our audience, sir. Before concluding, any take-home message from your end?
Monitoring, assessing, educating our patients is very important, and today utilize the AI tools that is available for an early detection, saving your time and predicting what can happen in the future, because patients are much more educated on AI and we have to cope up with them and give them the opportunity of trying what is available in the society, in the country, so that you prevent an economic burden both for the patients and for the country. Thank you.
Thank you so much, sir, for joining us today. It's a pleasure to have you here, sir. Thank you so much.
Thank you.